الله الرحمن الرحيم.
هذا بلدا آمنا وارزق أهله من الثمرات من آمن منهم بالله واليوم الآخر.
صدق الله العظيم. Therefore, allow me to take only 5 minutes from your valuable time outside traditions. This day will be the Valentine Day of MC activity. The day to say thank you for some persons. Thank you for the greatest teacher to us in medical field. Thank you for the patient, for his patience about his disease and sometimes his patience about us. Thank you, the police, for your patience. Thank you for persons doing the service, sacrifice not only their life, but sometimes the lives of their family for the best interest of the hospital. Thank you for persons working here since the hospital. Thank you for our Professor Dr. Mustafa Osman. Now, I will be away from a traditional or professional lecturer. I will be a postman. Why a postman? Because my message today is important to everyone. Anyone here need to save the life of a patient? Yes or no? If yes, please pay attention to this message and carry the message to the others. My message today will be in the form of a summary. What is the summary of the lecture? The summary is the message from the patient, either male or female. Please pay attention and assess my risk factors for thromboembolism. Why? In the HASSA area, there is multiple risk factors. There is dehydration, hot weather, immobilization, sickle cell disease, prolonged immobility in the hospitals, operations, bowel diseases, autoimmune diseases, all of this representing risk factor for thromboembolism. Even your colleague will ask you, I will go to India 4 or 5 hours by long flight. It is a risk factor. You must advise here in evidence-based manner. I will be restricted to the time, but please pay attention to the conclusion. Why thromboembolism is important? For example, in America, the death from pulmonary embolism every year greater than the combination of this from AIDS, from breast cancer, and the car accident. This is in America. While the situation in United Kingdom, the situation in United Kingdom is important also. If you see that 3 items I need to pay attention. Now, it is the third most common cause of maternal death. And coming after sepsis and the preeclampsia, as we mentioned by Dr. Kamal Fouad, I need to compare the death in this year to comparing this in this year. And how the guideline, when it is applied and followed and audited, give good result. Do you see the number here? Compared to the number here, there is a dramatic decrease in the incidence of pulmonary embolism. Why? Scientific guideline to be applied and followed and audited. Thromboembolism is important, and actually, this is to refresh our mind what is the cause of this. I need to mention that pregnancy itself carries a great risk for thrombosis greater than oral contraceptive pills. So it is very important. Why the pregnancy carries this risk factor? As all of us, because there is what is called Virchow triad. What is Virchow triad? Where Virchow triad is present, the risk of thromboembolism is present. The triad composed of a flow of the blood, in addition to abnormal in the epithelium and the increasing in hypercoagulability state. Unfortunately, all this triad present in pregnancy. So the pregnancy is a risk factor. Where the Virchow triad is present, the risk of thrombosis increases. Pay attention from this. How the stages occur from compression of the pregnant uterus about the veins, for example, how the vascular damage is occurring with vascular complication during maybe preeclampsia causing like this, how the hypercoagulability state during the pregnancy, because hypercoagulable factors like factor 5, factor 9, factor 10 increase. In this picture, if I say that thromboembolism is common on the right side than the left side, I am right or wrong? Yes. Why? This is the picture say that in the left side here, the right iliac artery compress the left iliac vein. So 80% of thromboembolism, even thrombosis occurring in the left side. However, the shell triad is present, the disaster can present. What is this? We can see. This is the shell triad are present. The thrombus is formed in the lower limb. After that, detached. After being detached from the lower limb, it runs in the vessels to run to the heart, and from the heart to pulmonary vessels, and causing pulmonary embolism, where the case fatality rate is high. Bad news. Yes. Okay. But still that's good news. What is the good news? Good news mentioned is that many pulmonary embolisms are preventable with appropriate thromboprophylaxis. We can prevent up to 2/3 of thrombosis by appropriate thromboprophylaxis. Where the National Institute of Health and Clinical Excellence in United Kingdom estimated that low molecular weight heparin reduces the venous thromboembolism risk in medical and surgical patients by 6 to 70% respectively. Not eliminate, but reduce the risk. So it is reasonable therefore that it may reduce the risk of venous thromboembolism in obstetrical patients by 2/3. If you assess the risk factor, giving the appropriate thromboprophylaxis in appropriate time, you will decreasing the risk, and this is the message of medical and paramedical persons. What's the guidelines about this? I will discuss about guidelines during the pregnancy, during delivery, and after going to the home in rapidly. If you are a person in MCH, either a doctor or a nurse, and you will suffer and you confronted with a patient, and from the history, the patient had a history of thrombus in her or first degree relative, you must assess the risk factor for this. And if the patient is risk for thrombosis, you must send her for persons with great experience in thrombosis. Assist the patient and send her for the persons with good experience. So your role as a doctor or a nurse to assess the risk factor. Do you see this risk factor? Please pay attention. How many risk factors present in our hospital? Peripheral venous thromboembolism, thrombophilia, medical, age more than 35, obesity, variant more than 3, gross varicose vein, multiple pregnancy, preeclampsia, cesarean section, postpartum hemorrhage, surgical procedure during cesarean, one-day surgery. Our colleague, Dr. Jamila, and her colleague, all this risk factor, hyperemesis, ovarian hyperstimulation, admission to the hospital in 2 days, systemic infection, postpartum wound infection, long distance travel. We are in the era of risk factor in this area. I am true? Yes. So pay attention, please. Again, any woman at high risk for thromboembolism must be given a proper counseling before get pregnant and after pregnancy with a clear plan about the management. Your role to send her for the persons who has experience in this. And the inhibition come to you with a history of thrombus, unprovoked, or with minor risk or with minor cause. I have a thrombus but no clear cause for her. Put in your mind a term. What is this term? It is with a term. What is this term? This is called thrombophilia screening. What is the thrombophilia? Thrombus means thrombus, philia means love to form a thrombus. It is either acquired or inherited, but ask the patient to do thrombophilia screening for like protein S, protein C, and thrombin 3, for example, and send the result to a person who can interpret it. Why? Because if this patient before pregnancy carries a thrombophilia, the plan during the delivery, during the antenatal and the delivery and the postpartum will be changed. So pay attention to the term thrombophilia, and you must review what is the thrombophilia. During the antenatal, please, don't be late, because as we see, most of the deaths can occur antenatal. If I recommend thromboprophylaxis with pharmacological method, what is the best drug? Unfractionated heparin, traditional heparin, conventional heparin, or low molecular weight heparin? The studies mentioned that low molecular weight heparin is effective and more safer than heparin. Why the low molecular weight heparin is more safer and effective? Only I will take 2 minutes to mention this. During bleeding, how the thrombosis is occurred, or coagulation occurs, that's intrinsic factor and intrinsic factor, leading to what is called cascade, leading to activation of factor 10 to be activated factor 10, which coming over thrombin, leading to activation of thrombin, and it will acting as fibrinogen to forming a fibrin and cystatin. I want to pay attention to factor 10 and the factor and the thrombin. Pay attention in the next slide, please. This is the difference between unfractionated heparin and low molecular weight heparin. Unfractionated heparin has a long polysaccharide chain compared to low molecular weight heparin. The low molecular weight heparin will conjugate with antithrombin forming a complex. Come, I will form with you a complex. This complex will come to activated factor 10. I will inhibit your action. And this complex will occur, the inhibition of activated factor 10 leading to antithrombotic action. Antithrombotic means prevention of the thrombus. When this complex coming to the activated factor 2 try to inhibit, it has a short polysaccharide chain. So no place for activated factor 2 to be joined, leading to partial deactivation of factor 2. And this is advantage where the anticoagulant of low molecular weight is decreased, so the risk of bleeding will be minimized. If I compare to unfractionated heparin, it will combine between antithrombin and unfractionated heparin, and with some product leading to complex deactivate factor 10, same activating a factor 10, but he will deactivate also factor 2 or thrombin, leading to anticoagulant and bleeding tendency. So low molecular weight heparin has antithrombotic and minimum or no anticoagulant, so the advantages of it is better. Again, unfractionated heparin working mainly on activated factor 10 and partially here, so it is more safer than heparin. Again, the same. So, if I comparing the smiley face with low molecular weight heparin with the sad one, unfractionated heparin, why you are smiling low molecular weight heparin? Because my ratio is high. Why high? Because I have antithrombotic action more than anticoagulant action. My deactivation of activated factor 10 greater than my action on factor 2, so I am smiling. Why unfractionated heparin you are sad? Because I have more anticoagulant action, the side effect in the form of the bleeding. So unfractionated heparin is more safer and effective. During the pregnancy, the patient will come with you. Please remember these numbers. In a woman with 3 or more risk factors. Do you remember the risk factor? If you have 3 risk factors, you should prescribe thromboprophylaxis with low molecular weight heparin. This is a risk factor again. 3, you must prescribe low molecular weight heparin or consider low molecular weight heparin. If the patient comes with you you are confronted with a patient, I am a patient, with a single, unprovoked, excluding estrogen, no other risk factor. This is I have a thrombus with unprovoked, not related to the estrogen, and not recurrent. This means I can recommend close surveillance for this patient, and the low molecular weight heparin is not mentioned as a routine, but postulated we must give. What is the exception? When I prescribe low molecular weight heparin for a patient with thrombosis, if the patient have more than one thrombus, if it is a recurrent or related to estrogen like pregnancy or oral contraceptive pills, or the family history has a thrombus first degree or thrombophilia, يبقى there is criteria to mention molecular weight heparins or thromboprophylaxis during the pregnancy in a patient with previous thrombosis. Must be estrogen related or recurrent, family history positive either by the thrombus or thrombophilia. We must be giving thromboprophylaxis. As we mentioned, you must ask thrombophilia. Why? Because if you request the patient thrombophilia and get positive, this patient needs antenatal thromboprophylaxis. You can manage it conservative or with monitoring hair, but when you recommend to giving low molecular weight heparin, if the patient has multiple factors of thrombophilia, if there is antithrombin deficiency, if there is other risk factors, you must send her for persons with experience or recommend low molecular weight heparin. The patient now with heparin and coming to you during labor in the ER or calling you at home, I'm having a liver pain and I am receiving heparin. What is the advice as a nurse or a sister? Please, patient, don't inject you the further dose. Come to the hospital. Once you come to the hospital, the medical team will evaluate to give the dose or no. Why? Because we are afraid from hematoma during the epidural anesthesia. So you must mention to tell the patient this: if you're receiving heparin, low molecular weight heparin, and you're suffering from bleeding or labor pain, don't inject yourself. Come and in the hospital, we will assist you. Am I clear? The patient comes to the delivery room. We are now in the delivery room. What is the role of the sister and the doctor? The sister and the doctor is to reassess the patient again. Reassess the patient again. This is our message. Assessment. You must assess her for the risk factor and put the plan for her regarding thromboprophylaxis, either after normal vaginal delivery or after cesarean section. And we must pay attention to the normal vaginal delivery. All women should be assessed after delivery for the risk factors. Please remember this. In delivery room, remember this sound, remember this movement. In delivery room, please, don't let the patient dehydrate. Water is very important, except in certain situations like PDT. And allow the patient to move. Sometimes Dr. Ashraf asks for continuous CTG. Sometimes we put the patient for continuous CTG. Advantages follow up the baby. Disadvantages increase the risk of thrombosis. During the normal CTG, allow the patient to manipulate. Remember, this is slide and apply, and this is a good message for you. All of us know macro maneuver. Yes or no? All of us for shoulder dystocia. All of us know Dr. Sigarabado for the CTG. Dr. Mustafa, do you know AAT equations? This is our colleague. I with Dr. Mustafa 10 years ago. He doesn't know. AAT equation put her in the delivery room to be the friend of Matt Robert and Dr. Sigarabado. A. Ashraf, ATIA, DEWIDAR equation. This is the theta. What is my yes? I mentioned that. What is this equation? Remember that question. In my equation, 2 plus 3 equal to not 5, 7. It is 7. My equation 7. After delivery, in delivery room, in 2A, in any place, please remember, if you discover 2 risk factor in any patient, after normal vaginal delivery, consider her low molecular weight heparin for 7 days. If you find the 3 risk factors, consider here low molecular weight heparin in addition to this nice elastic stopping. Remember this and apply. Okay? And send this message. I will send this message to delivery. Please to go to delivery. And 2 or 3 risk factors, please, for assessment. Pay attention to overweight. We have overweight, obese, grade 1, 2, 3. Obesity is moderate risk factor for thrombosis and must be respected. If you find any patient in the delivery room after CS, after normal delivery in your ward, and it is morbid obesity, don't hesitate to consider this is the body mass index. This patient will remember there is overweight like me and obese, morbid obesity, grade 3. Pay attention to this, and this is thromboproflectis is important. Why? We are now in the era of cesarean section, or levels however, and the incidence is increased. There is difference between emergent cesarean section and elective cesarean section. Emergent cesarean section per se is a risk factor, and the protocol now, if there is emergent cesarean section alone, we must consider. What is the meaning of consider? Pay attention to this and think deeply with tendency to give thromboprophylaxis with low molecular weight heparin in addition to other factor for 7 days. This is emergency. Why the situation in elective cesarean section, if there is elective plus 1 risk factor, gives the thromboprophylaxis for 7 days. Any patient who receives thromboprophylaxis during antenatal due to either thrombosis or thrombophilia must be given thromboprophylaxis after delivery. We can argue in antenatal, give or not give, but with cholesterol, any patient with risk factor thrombophilia thrombosis must be given, no discussion, must be given. The discussion about the time for 6 weeks for more forces. So no discussion in post-delivery thromboprophylaxis. For example, patient with thrombophilia getting for 6 weeks. Patient with thrombosis with heterogeneous thromboembolism for 6 weeks or greater than that. Any patient was in heparin, for example, during the previous thrombosis, before the pregnancy, during the pregnancy you're giving her heparin, and after delivery you must be giving her heparin or warfarin. We can shift to oral. But please, we need to mention that warfarin and low molecular weight heparin is safe with the breastfeeding. But don't give warfarin at any time. Must be given where the time of hemorrhage is decreased. So the shifting from heparin to warfarin must be occurred after 5 to 7 days of delivery. Don't start from the 2nd day or 3rd day because the risk of bleeding is increased. I am sorry for the time, I will be summarized. I need to mention that if any patient admitted after delivery for any reasons, for wound infection, for the product of conception, for anything, you must reassess and write in ER paper. My assessment for risk factor 1, 2, 3, 4. My advice are as ROD like this, red lines or highlight this for the specialist and the consultant to observe. This is your role and the role of the sister in ER. If you admit patient with infection like this, in post-cesarean section, at least 7 days, and the patient with extended duration in the hospital, give the patient low molecular weight heparin for 6 weeks, even the patient to go home. This is very important one. From 7 days to 6 weeks, 7 days at least. All of us know that the doses of low molecular weight heparin either prophylactic or hyprophylactic or therapeutic. Prophylactic or hyprophylactic or therapeutic. Our discussion about prophylactic and hyprophylactic. What is the contraindication for low molecular weight heparin? Everything was contraindication. Woman with active or postpartum bleeding, and also item we can read the contraindication. In your box, there is the same are present in the box where is the risk factor for antenatal and what is the recommendation. We can read after the finishing, we can classify high risk, low risk, intermediate risk. What is the appropriate thromboprophylaxis? This needs to be read carefully and put in the word for everyone and must be as a routine part in our files assessment. And when the American team coming, they mentioned this. I asked her about the thromboprophylaxis. They mentioned that all the doctor must write evaluation for risk factor and write in the file. And the person who neglect or forget to do this will be under not investigations, evaluation for why he neglect very important risk, important step like this. This is the antenatal, again, assessment of antenatal, and this is the assessment of the postnatal. It is available with you. This is my lecture. If one needs to copy, it is available in the website. Basal Stream, complete one. Finally, I need to pay attention that not cerebellum or low molecular weight heparin or disability methods. We need to remember that water, avoid dehydration, movement, mobilization, very important to be mentioned, elastic stocking, pneumatic, intermittent, pneumatic compression machine was available in our ICU and broken and after that disappeared. And this is very important. Some studies comparing pneumatic compression machine with the effect of heparin and low molecular weight heparin. So very important. This is slide responsibility of everyone here. We must write mobilization, hydration, elastic stocking. It is not a pharmacological one. We easy to write, we easy to educate the patient about this in addition to low molecular weight heparin, and sometimes we can using fractionated heparin. I need to mention that the follow-up of low molecular weight heparin usually doesn't need follow-up, except if you give the patient before low molecular weight unfractionated heparin, you can ask to do platelet count because unfractionated heparin causing thrombocytopenia. Okay, and in certain situations like very thin patient, very obese patient, renal function is not good. Sometimes we need follow-up for this patient. But in general, remember this is fine. I need to mention that we are working together as a multidisciplinary team, a team work, not a person. Don't say that the consultant will do this, the specialist will do this. You, all of us, medical, paramedical, even the general people are responsible for evaluation of risk factor. Your neighbor will ask you, I will travel, I'm pregnant now, my ancestor like you, I will travel to Philippines like this and I am pregnant. What's my advice about risk factor for thrombosis? At least giving here, don't drink coffee or tea, please elastic stocking, give aspirin, dehydration. This is the advice, can save her life. This is not a joke, it is a serious. I need to mention that for next slide and the last slide, there is what is called anteater. This is animal who suck the animal. And I need if everyone here working alone, not as a team. What is the result? And what is the result if we are working a team? Observe this and to compare our situation to the way of ant. This is the ant working in very nice, and this is the cheek here, the head. This is the ant sucker. He takes this. You need to take this. This is the team working. We can overcome with teamwork. Finally, thank you very much. اللهم انت ربي لا اله الا انت خلقتني. Yes.
Without that, you see, I have 3 people in the audience. No, 2 of them are here. Then we start with the Ashraf ATIA. He's a powerful speaker. You see, no matter how tired you are, you want to listen to him because he will make the subject look as if he it is his own subject, business, that wants you to be part of it. That is the power AAD has. Another person is the one with the capturing voice. That's my friend Thomas Fuad. Whatever he is talking to you, you have to listen. And you will enjoy the lecture. The third person is the one with the awakening voice. He's not here. Muhammad Khalid. If you are just waking up, he will make you to enjoy his lecture. We thank you, AAD.